Welcome back, I hope. Yes, well, it didn't go back to where I had it before. Excuse me while I fast forward. We'll get through it quick.
Why did Pinocchio go down?
I don't know. Part 2 of the GI lecture, and we were just talking about.
You
kind
did
of-
push record.
I did press record, yes. Do you want me to? Okay. This is what I did last time, so.
Okay.
All right, kind of moving in, and that was a lot of acute care stuff, but it is important for you to understand because you will get patients that come in with cirrhosis. You'll get patients that come in with chronic pancreatitis, abdominal pain, all of that stuff is pertinent in gallbladder disease. So it even though it is more acute care, it is super important. So we'll start kind of upper GI now, talking about nausea and vomiting, which is a common complaint and somewhat difficult to determine it sometimes. So the pathophysiology is listed here. It's kind of all over the board, usually caused by noxious stimulation of the vomiting center. But as you know, it's not always a GI thing. It could be something ENT, could it be, you can get chronic diseases that causes nausea. So really, we'll be talking about going into history and stuff. You got your patho here, but when we diagnose things with nausea, vomiting, we're not really we think about pathophysiology, but again, the history. That's I can't stress that enough. So we're talking past medical history, including eating disorders, past surgical history, medications, sick contacts, all of that. Again, onset, timing, duration, frequency. Patients will say, "Oh, I've been vomiting." Okay, well, how often have you been vomiting? "Oh, I just vomited once." Okay, so that's pertinent. If you're vomiting once, and they'll say, "Oh, okay, when was that? Was that within the last week?" "Oh, that was about a month ago." Okay, so they're not going to take you to that. So, or are they vomiting 10 times a day and they can't keep fluids down? So it is important. The characteristics of the vomitus, is there blood there? Are they throwing up full food? Does it have, it usually does have an odor to it. Or is it just bilious looking material? Are they just throwing up bile? Associated symptoms, very, very important. Abdominal pain. Do they have abdominal pain with it? Do they have fever, chills, constipation, diarrhea, GI bleeding? Also, again, we've had patients come in and, they're sent to us and they're saying, I've been getting real dizzy, and symptoms of vertigo or, ringing ears, things of that nature. So we don't always think about that in the office, but if we're not really getting to where, we're figuring out what's going on, you start talking about that. Also, patients come in quite often too with history of migraine headaches, and, when you delve into the history a little bit more, okay, well, tell me about your headaches. How have those been? "Oh, those have been terrible. I've been getting migraines about twice a week." "Okay, well, do you usually get nausea with migraines?" "Yeah, I do." I'm like, okay, that's probably where we're headed. Differential diagnoses for nausea, vomiting, all over the board. Again, getting a good med history. Medications, I feel like sometimes we do not look into that enough. Again, polypharmacy is a huge issue. So when you get a patient coming in the office, they're there for 15 minutes, and you got 15 drugs listed there and don't know if, maybe something's causing it. It takes some time. And so sometimes what I'll do with patients is have them come in and get their thing. If I'm not really sure what's causing their symptoms, I will go over their med list at home and look up all their drugs again, because I don't always know what all the side effects are. So infectious diseases, certain GI disorders can cause that. You got your CNS issues, migraines is a big one. You have, psychogenic causes for nausea, vomiting as well, endocrine issues, pregnancy, uremia. It's all over the place. So really the history is so very important. Treatment. So definitely treating the underlying problem, and then consider just continuing any offending medication. Now, I say that, but be careful. So depending on what the drug is, like, patient comes in and we are thinking maybe this is a cardiac drug, something that's, pretty important. We might not, do that without saying, is this okay with your cardiologist? But we really have this feeling that it completely coincided when you started the drug. So we're kind of mindful of that. But meds are often a decent cause of nausea, vomiting. Drug therapy, definitely, again, it depends on the underlying cause. So you got all these antiemetic type agents listed here. And so depending on what we think is causing the symptoms, either we're holding a med, or if we think, perhaps the patient has gastroparesis, we're waiting on gastric emptying study, do we put them on a prokinetic agent? I've never prescribed dronabinol in the office setting, but certainly we have in the acute setting at times. Benzos, I do not prescribe benzos in the office.
For nausea?
Yes. Okay. And not for nausea.
Oh.
But more or less, sometimes we'll talk to primaries about if a patient has anxiety, and if nothing else is helping with them, but yet when they seem to take their Xanax, they feel so much better and their nausea goes away. So I would say more or less talking about treating the underlying cause again. Is this related to anxiety or depression or something of that issue? Do we need to think about treating that psychiatric disorder? So while that's there, it's not something I'm prescribing in the office.
Okay.
I do not. And we'll get into it with IBS, but one of the treatments is SSRI therapy because serotonin receptors are all in the gut. But again, my comfort zone isn't prescribing that, but I might refer back to their primary because I'm not going to follow up on that. But it can help rule things out. Like say if we have a patient who comes in with nausea, vomiting in the hospital, and we notice, and sometimes you put them on Zofran and the Zofran's not doing the compazine. Their bowels are working on all this stuff. Maybe you try a low dose Raglan, and then this patient might have a history of anxiety. Do we see if they might prescribe sometimes an anxiolytic to see how they respond to that? So not regularly. Antidepressants, we have to start thinking about that. And patients are pretty sensitive to, they think there's an organic issue sometimes with all symptoms, whether it be pain or nausea, vomiting, and it's a slippery slope talking to people. Sometimes people can get kind of defensive about some psychogenic factors, but I always say there's a reason for everything, and so sometimes it's just thinking outside of the box. We've ruled out organic problems, we've ruled out all this other, maybe we need to start thinking about other causes for your nausea, vomiting, like anxiety. Gastric pacemaker, that's more related to gastroparesis, and so that's definitely a referral thing, and that's down the line for patients with, some patients have idiopathic gastroparesis, but more so patients with diabetic induced gastroparesis, and then surgery is pretty rare. Nausea, vomiting, when to refer, unexplained chronic nausea and vomiting, and then the further workup is kind of depends on underlying symptoms. A lot of times we will do an EGD, we'll rule out gastritis, we rule out ulcer disease, anything, gastroparesis. If they come in and they're MPO since midnight and they have a stomach full of food at 8, 9 in the morning, when they were really NPO, do we have that going on? So, and then we kind of rule things out, and then we'll refer to other specialists if we need it, neuro or psych or endocrine. Reflux, sometimes, the incidence, it's kind of shady out there. There's not an exact, the epidemiology is kind of vague. It's difficult to estimate because subjective versus objective evidence of, we're not scoping everyone that might have reflux symptoms. Do we know they have reflux? So we don't really have an exact data for that, but then you ask about 10 to 20% of patients experience GERD symptoms. It's most frequently in adults. Pathophysiology of that, just backflow of gastric contents from the stomach to the esophagus. You can be symptomatic or asymptomatic. Not everyone comes in with heartburn, but maybe they have a feeling of fullness, or maybe they're belching a lot. Mechanisms for that, you get some lower esophageal sphincter relaxation, a hypotensive lower esophageal sphincter. You get hiatal hernias, which patients mistaken often for, I have a hernia, and they think it hurts, or they'll have pain. And I said, well, unless a hiatal hernia is just super large, it's probably not going to cause discomfort. But I tell them it does contribute to reflux symptoms, so it doesn't typically cause pain. Intra-abdominal pressure, so obesity, it's another one. I tell my patients all the time. When I gain 5 to 10 pounds, I definitely have worsening reflux. I mean, there's just, There's, it's definitely something that you can work on, where we'll talk about lifestyle modifications for that. And then pregnancy and estrogen, increase in estrogen. Clinical presentation for obviously your heartburn, regurgitation, or feeling like you're throwing back up acid. Dysphagia, which by the way, you can get like what we call a globus sensation, or a feeling of a lump in the throat, and sometimes it's difficult to discern in patients. Do they have just real dysphagia or trouble swallowing, or are they feeling this globus sensation, or feeling a fullness or a lump in their throat? And they'll say, like, I'm having trouble swallowing. Or are you having trouble swallowing that liquid, the pills, the food, or do you feel like just lump in the throat that won't go away? And so sometimes it'd be difficult with dysphagia.
So what is usually the lump in the throat?
It's caused by reflux. You probably they're just silently, yeah, they're not experiencing that heartburn symptom. They might just be reflux, and you get that acid, you get that reflux or regurgitation back up, and it causes almost like a pressure feeling of a lump in the throat. Dysphagia is not, if they have true dysphagia, if they tell you they can't swallow, or they swallow a pill that's getting stuck, or food or liquid, that's not normal, and that needs endoscopy. We'll talk a little bit about that in the future. Chest pain also, hypersalivation, nausea, sour taste in the mouth, belching is a big one. Coughing or hoarseness, definitely hoarse throat, or a hoarseness, and then sore throat. Not so much, I've not seen so much dental erosions, but sinusitis, chronic sinusitis, sometimes, patients will have, you can definitely reflux under the sinuses. Chronic cough or asthma-like symptoms. Differential diagnoses for that: esophagitis, peptic ulcer disease, generalized dyspepsia, or like a functional dyspepsia, biliary tract disease, again, cardiac. Rule out your cardiac stuff. They come in complaining of chest pressure or chest fullness. And then also esophageal motility disorders too. And usually that's with someone, in our older population, we'll start to see that. Diagnosis, you can diagnose based on symptoms alone. But I feel that eventually there are now exact guidelines, but eventually, and we'll go into this too, about who needs an EGD. If you got someone with chronic reflux symptoms and they've been on a PPI or H2 blocker for years, you probably should at least get them scoped once. NURD, or non-erosive reflux disease, there's symptoms, you get symptoms of reflux, but there's no visible endoscopic findings of reflux. So we go into that patient, we do an endoscopy, and we're not seeing reflux there. We don't see esophagitis, we don't see erosions. It doesn't mean they're not refluxing. It just means that they might not have damage. And then GERD is usually, you have the endoscopic findings at that point. We can do pH studies on patients. We basically put a pH probe down there. If they're on acid suppression and things aren't really working, or you're dialing up on all their medications and we're not totally convinced that they're refluxing, we might do a pH study. And then sometimes we'll do other esophageal studies as well. Indications for EGD. So, patients with alarm features. So, dysphagia is not normal. Or dinophagia is painful swallowing. Those will definitely get you an EGD. Any symptoms of GI bleeding, anemia, weight loss is another one, or recurrent vomiting. If patients have a history of severe erosive esophagitis on initial endoscopy, we'll ask them usually to follow up in a couple months to make sure that things are healed. So just making sure that the medication's working. Barrett's screening, risk factors for Barrett's esophagus, and I'll talk a little bit about Barrett's. If you have someone with a history of chronic GERD, again, they've had it for years, they've been on acid suppression for years, but no one's ever really kind of taken a look down. Hiatal hernias, patients with age greater than 50 in males, male gender, also Caucasians, and elevated BMI. Now that alone is not, and you get a obese patient that doesn't really have symptoms, are we scoping them? No, but if they have multiple risk factors with chronic reflux, they'll probably just want to take a look. And then any patient with symptoms that persist despite, maybe a 4 to 8 week trial of PPI or acid suppressor therapy, in the office. So they come in complaining, they have classic symptoms, you put them on an acid suppressor, maybe you increase that to twice a day, and they're still not they're still having issues, then, by all means, send them to us. Barrett's esophagus, so it's a condition, basically it's kind of a protective thing that the body does to itself. You have that chronic reflux, acids refluxing the esophagus, and the cells in the esophagus or, at the end of the esophagus are trying to protect themselves from all that acid contact. And so they kind of, the cells change and they morph into, from what was metaplastic columnar epithelium, and then it replaces stratified squamous epithelium and kind of changes to morph to try to protect itself. It develops as a consequence of GERD, and what's different with Barrett's is that it predisposes the patients for development of adenocarcinoma of esophagus, and so those are your esophageal cancer patients. Of the patients diagnosed with Barrett's, and it's pretty low, but 0.1 to 2% of patients with Barrett's will go on to develop adenocarcinoma. And so in patients with Barrett's disease, it requires lifelong acid suppression therapy. And that's a big question with them. Can I go off my meds? No, unfortunately not. Can we get you down to like 1 dose a day? Sure, depending on the severity and symptoms. Treatment with high-grade dysplasia, so you're starting to see now cell changes in the esophagus. We have we can do resections of the mucosa there. We can ablate the area. Worst case scenario, if you showed high dysplasia, you might do an esophagectomy, and those are tough cases. Those are tough cases. And I would say mostly I'm seeing the people that are not doing well in the hospital, but that's always a last resort. But so the Barrett's patients need frequent screening too. So once you're diagnosed with Barrett's, you're pretty much coming in after initial diagnosis. You might come in a year to see how you're doing, and then after that, maybe 2 to 3 years, depending. And then you'll have biopsies of the Barrett's area. Some patients will have come in, just on a little aside, they might have very small area of Barrett's. Sometimes we'll see that go away. And then they'll come in for Barrett's and screen biopsies, and we'll keep biopsying and everything's negative. Then they may push you out to more normal, we don't need to repeat this as often, but more time than not, once you have Barrett's, it doesn't go away. Just some pictures here. Gastric esophageal junction, and then you're seeing a little bit of irregularity in the tissue here, some reflux damage, subtle. This is an example of ulcerative esophagitis. Is pretty gnarly in there. Barrett's, you kind of see these islands here. You have normal tissue, and then you have some islands of Barrett's tissue here. There's definitely these changes here of Barrett's esophagus. So when they go in, depending on how long that segment of Barrett's is, they'll go and they'll take biopsies every couple centimeters to look for cell changes on a routine basis. And then this is a Mallory-Weiss tear. This is usually caused by retching and vomiting. And it is a cause of GI bleeding at times. So you can't see it here, but there's probably a little linear tear here, and it just caused some bleeding. Lifestyle modifications. So easy for our patients to come in, and they're saying, they want meds, they want things, they want it fixed, and we're happy to help them with that, but here we need to really go over what you can do to help us control your symptoms, because I tell them we can throw all the medications that we can, to try to treat you, but unless we treat underlying issues, might keep going on. That being said, I have patients who pretty much follow everything to a T. There are patients that do that, and they still come in and they're still having issues, and then completely understand, but it is helpful. So weight loss, that's a big one. Like I said, even a 5 to 10 pound weight gain can cause an increase in symptoms. So I'll tell them, I'm like, hey, don't look at your overall weight loss. Don't be like, I've got to leave 50 to 100 pounds, lose 50 to 100 pounds. Okay, well, let's start with 5 to 10, see if your symptoms are better. Elevation of the head of bed at night, if they have nighttime symptoms, and definitely avoid eating and drinking 2 to 3 hours before you go to bed. Even if you're drinking something, have a little snack before bed, you're secreting stomach acid, you lay down, you're going to reflux that. Dietary triggers, fatty foods, caffeine, chocolate, spicy foods, all the good stuff. Carbonated beverages to peppermint. Now, I will say, peppermint supposedly exacerbates it, but some patients will tell me that they try peppermint, which seems to soothe things for them. But again, I try to get in the habit of going through all their dietary stuff in the office, because sometimes I will surprisingly get someone who, I had one lady who came in and was like, and was just asking about caffeine use, and she was pretty much drinking 2-liter bottles of soda a day. I'm like, okay, well,
Wow.
I mean, we got to dial this back for sure. I said, I know you need a bit. I mean, but it was insane. It was an insane amount. But I almost kind of like, not that I didn't play it off, but I sometimes depending on time, we can't delve into every trigger that you have, maybe. But that was a surprising one for me. She came back, she cut down, get back, and was like, oh yeah, symptoms are way better. Good. Eating smaller, more frequent meals. Definitely avoid tight-fitting garments that can put pressure on the abdomen. Sometimes patients will come in with tricks. Chewing gum might help, or chewing on lozenges if you have sore throat from it. The chewing gum is interesting. I had a patient complain of reflux, and she was just chewing so much. She was like actually swallowing a whole bunch of air, and then had all this aerophagia. She was belching constantly. So, I mean, we use that's in here, but just keep in mind. And then avoiding tobacco and alcohol, which can reduce the lower esophageal sphincter pressure. Medications. So I often tell the patients that medications, the way we treat you is kind of on a tier. So you have your antacids, which are on the bottom of the tier. Their job is to neutralize stomach acid, so that's your Tums, your Gaviscon. It's fast act. They work quickly, but they are very short acting. So if someone's on medications, they might have breakthrough symptoms. I'll say, yeah, go ahead, take a Tums in between. If you have a breakthrough or a bad day. Surface agents are things such as Carafate. And really, I would say we use these in patients who they come in and they have bad erosive esophagitis and we need to just coat things, or they have just a lot of complaints of esophageal, and we just kind of want to get them over the hump so they can kind of relax. And you're like, okay, you just had this EGD, it's not horrible. Let's try a little Carafate to see if we can coat things and make things more comfortable for you, but it's not something I regularly prescribe. Then next on the tier, step up, histamine, H2 antagonist, so it's your Zantac and your Pepcid. There's a slower onset of action, but it lasts longer, obviously, than their antacid, so about 4 to 10 hours. And then on the top tier is your proton pump inhibitors, so which inhibit gastric acid secretion differently than H2 blockers. So you got your Prilosec, your Nexium, Prevacid, and these are all just the brand names here. Treatment approach is kind of remain the same, that what we were calling the step up versus step down approach to therapy. I would say increase, when they come to our office, I'm either using an H2 blocker or a proton pump inhibitor, depending on their symptoms. So step up approach, obviously, I'm usually never starting with Tums or Gaviscon with patients. They've already tried that, it's not working, I need something more. If I think they're mild symptoms, maybe I might start with an H2 blocker. But we always talk about, we'll get you on some acid suppression. We want the minimum amount of medication to keep you comfortable. And then, so step up, obviously, so, you have your Tums to your H2 blockers, your PPI. Step down would be top to bottom. I would say in general, okay to discontinue acid suppression in an asymptomatic patient, with the exception of those patients with that history of severe erosive esophagitis or Barrett's. They need maintenance proton pump inhibitor therapy. Sometimes we'll have patients that they can't tolerate the PPIs, and then we'd have to go to an H2 blocker, but usually those patients are on proton pump inhibitor. One thing to mention with your patients, and I think they think that these acid suppressors prevent reflux. And I think if you could explain to them that they do not prevent the action of the reflux, they cut down on the amount of acid secreted by the stomach, that helps them. It kind of gives them a little bit of an aha moment. You're like, we'll cut down on the amount of acid secreted by your stomach, which will result in less acid refluxing, but it doesn't stop the action of reflux itself. So again, symptom management, mild to intermittent symptoms, you might try to step up therapy. You might change therapy. I would say 2 to 4 week intervals. I'm seeing that our docs, and depending on, some of us in the office are saying, telling patients, give it a good 4 weeks before we're, increasing dose or changing a med. I will usually check in with a patient in about 2 weeks and just see if they're improving. But more times than not, they're saying, give it a month on an acid suppressor. It can take some time to control the symptoms. In a minute, in the interim, if they want to use like a Tums or a Gaviscon, or you want to add on like a Pepcid or a Zantac at night for nighttime symptoms, fine. But just give the meds a chance. Increased, usually depending on the drug. We have one drug that's 24 hours. None of these drugs are 24 hours. I just want to reiterate that. So sometimes we have to increase the dosing to twice a day, which we do. And sometimes even we'll add on, if we use a proton pump inhibitor, typically dosing is, in the morning, half an hour before breakfast and a half an hour before dinner. And then if they have nighttime issues, we'll sometimes add on an H2 blocker at night. Just to, more 24-hour coverage, depending on the severity. Again, severe symptoms, probably starting more with a step-down approach. So, maybe we went in with the EGD, maybe we have erosive esophagitis, so we're starting with the PPI, maybe once to twice a day for 8 weeks, and then maybe dialing it back, depending. Potential risks for PPIs, like patients do come in with this. Recent studies, probably over the past year, there was some study, it was a smaller study, and they were saying that there was a higher risk for patients who, their patients were developing dementia as a result of some acid suppression therapy. And our doctors actually sent out a letter to all of our patients saying, based on the studies, it was a smaller study also, you don't know what the underlying comorbidities of all these patients are, so what is their age? What are their comorbidities? What are other issues? And so we told our patients that basically, we get studies every once in a while that come out, and PPIs have had kind of a bad
Cardiac issues.
Yeah. Huh?
Isn't there a recent study, I thought, with cardiac?
Yeah, there's cardiac, and then there was cardiac meds with Plavix and blocking the effectiveness, the efficacy of Plavix. But that's kind of died down in itself. Some medications will use different PPIs to control that. We'll dose it, separately from Plavix. But this was more recent study with the dementia thing, and people were coming in just freaked about it. And we tell them, all of our docs went over it, over the study. It was a smaller study. We have to be mindful of, the patient, the population of people that they're doing, and really there has to be more research done on all of this. But that being said, we tell the patients, it's risk benefit. What's the risk of stopping your medication versus the benefit? We weren't stopping patients on medications just because of this study period. So being mindful, and looking at a patient's history. Sometimes, enteric infections were suspected too with C. diff. You're altering the amount of acids, secreted by the stomach. Is that allowing for other issues? And enteric infections like C. diff. With patients with treatments with C. diff, if a patient has a history of erosive esophagitis or Barrett's, we're not changing their therapy if they've had C. diff. If it's something that we control with a different acid suppressor, then maybe we're changing that. But we haven't had a lot of hubbub about that lately.
Do you guys advocate for probiotics for stomach health, gut health? Just out of curiosity, with all of these risks, and you were talking about C. diff.
Yeah, I'll talk about that a little bit more with irritable bowel syndrome and probiotics.
Good. Okay.
It's verdict's still out on probiotics.
Okay.
Probably for reflux, probably I'm not using a probiotic on the patient unless I feel like their symptoms are kind of like dyspepsia, not totally related to reflux, and maybe they need some sort of balance. There's differing opinions on probiotics for sure.
Okay.
Malabsorption, when they are finding some deficiencies in B12 and magnesium, so now We might be checking B12 and magnesium in patients with PPIs about once a year. I have had a few patients that have needed B12 supplementation, and whether or not that's related to the PPI, not totally sure. But I do give the patients the option and say, hey, we can check this once a year if you want. Most patients are like, no, that's okay. But some we do.
Do you check it no matter what, or only if they've got like macrocytosis, or like if they're
Symptoms, I watch for symptoms. Yeah, weird.
like if their MCV is elevated?
Yeah, I mean, for sure. If you're diagnosing an anemia, maybe. I would say, have I been generally checking everyone's B12 and magnesium? I will admit to no.
Okay.
But I do talk about it with everyone that's on long-term acid suppression. I will say, we're seeing that some patients are developing this, not everyone, maybe a lower incidence. We can check it once if it's, and then I do have some docs that are regularly doing that. Is it recommended all the time? I don't believe it's like a.
It seems like, if we were in primary care and they're on a PPI, we put them on a PPI, and you're checking like regular labs, and then if they would have some macrocytosis, then you would maybe dig into it further, right? Not just like randomly draw B12.
But maybe it isn't going to cause, we don't know that it would maybe cause the macrocytosis at that point either, so.
Something that they could
It might
think
be,
about.
yeah, it's definitely worth thinking about. Just checking it once a year, or at least once baseline, especially if they've been on it for like a year or longer. We might check, you might have increased gastrin levels, or I've not seen patients develop atrophic gastritis from this, but a potential risk. I've not seen anyone develop interstitial nephritis from it. And then talk about drug interactions again. Back to the pharmacology days, is just always watch whatever you're putting your patients on. We're altering, gut, we're altering acid secretion. We're dinking with that when that's involved in, medication and breakdown. When to refer patients with refractory symptoms who fail to respond to therapy, and also anyone who meets the criteria that we talked about with the EGD. Surgical interventions, still kind of at the top of the list for patients who've kind of failed all treatment. Therapy is innocent fundoplication, that's the most common. The thing with innocent fundoplication, and I'm not an expert on this by any means, they last maybe about, the way the surgery does it, kind of anatomically they kind of create like pressure on that end of that sphincter. With the surgical, the way that and I forgot if they create like a pocket or they bring it up around. Yeah, up around the esophagus.
Yeah.
It's the average that lasts is about 7 years. So maybe.
What about a TIF? How long does that last?
What?
The transoral fundoplication, where they like go in?
I don't have the answer to that. And so, it is last resort for me to. And by then I'm talking to the doc and being like, okay, maybe we've done the pH studies, we know that they have reflux, all their meds aren't working, what is the best road? I think our docs are still referring to surgeons for a Nissen.
I'm sure.
But you just have to tell them, it's not something that might last, and even in a couple of years your Nissen could slip and you're still having reflux, and we are seeing patients back on acid suppression. So, and it, never take surgery lightly. So I don't know the answer to that. That might be better for a surgeon to answer.
That's okay.
Gastric bypass for morbidly obese patients, it's not like a regular intervention that we would, but that, they can take care of. And then Link's prosthesis. I've had a few patients ask me about that. I don't know that the surgeon groups that we work with provide, I would say Freighter. I think there was someone at Freighter that we referred to someone to.
I have no idea
It's
what it
basically
is.
it involves like magnets, and it's.
Oh, I've heard of this.
So there's a weak esophageal sphincter, and then it's a ring made up of magnets.
Yeah, they weighed it.
But I haven't heard a lot about it, and so that was that was about a year or two ago. I had a patient come in, so I had to read up on it. She was asking, I'm like, I honestly don't know. So we still refer to our surgeons for refractory reflux. Peptic ulcer disease affects about 4.5 million people annually in the U.S. It's definitely a significant cause for morbidity. We see a lot of patients in the hospital for GI bleeding related to peptic ulcer disease and anemia workup. It's more common in older individuals. So it causes injury to the mucosa of esophagus, stomach, and the duodenum. And there's alteration in the secretory defense and repair of the mucosa. And you can get mild to severe symptoms. And you can definitely have patients who are symptomatic, have dyspeptic type symptoms, or you can have patients who are completely asymptomatic and they come in and they're anemic. And they're like severely anemic. But anemia in the case where they've been riding along probably for months and they come in with a hemoglobin of 6. And, so then even despite not real, we'll probably do a scope on a patient with no other factors going on that some underlying leukemia or issues like that. Causes of peptic ulcer disease, H. pylori, cause about 50 to 75% cases, which affects gastric acid secretion, mucosal defense and mechanisms. NSAIDs are a big one. And the thing to know about NSAID use is that, and patients will say, well, I'll take my NSAIDs with food. The NSAIDs have a systemic effect on the body by inhibiting prostaglandin synthesis. So just by simply taking your NSAIDs with food is not going to prevent peptic ulcer disease. It's probably maybe less irritating in the gut, but so that is another big one. Gastric acid hypersecretion, that a little bit, that's definitely involved. You have your drug-induced, so glucocorticoids, alcohol. You get your patients, and when I talk to my patients about NSAIDs, you have to ask them specifics. So I go through all the drugs. I'll say, do you take ibuprofen, Advil, Aleve, naproxen? Do you take Mobic? Do you take Cellars? Because
True.
Yeah, you have to, because they don't know, and so and they don't know what that means. So, and they're like, NSAID, what's an NSAID? Gastrinomas or Z syndrome, it's kind of, I'm not an expert on that, but I mean, it's something that we'll rule out in cases that we're having trouble with the diagnosis. And then infection, CMV or herpes can cause peptic ulcer, radiation, obviously, and then malignancies. Clinical manifestations, again, it can be completely asymptomatic, or you might have someone with pain, dyspepsia. Pain is primarily epigastrium, can localize right or left side. Mostly it's epigastric, a little bit off to the left, maybe sometimes. It can describe sometimes as a burning pain, gnawing, hunger-like pain, can be relieved with food. So you got a big ulcer in there and you eat food, it kind of protects that ulcer area, the stomach from attacking that ulceration. You can early satiety, anorexia in the elderly, nausea, vomiting. We're asking patients about dark black stools. If they vomit, do you have coffee ground emesis? And then, I remember this, I don't know if this was a board's question, but it was basically like pain with a gastric ulcer versus duodenal ulcer and what that felt like. And then the pain is like, if you had a gastric ulcer, that you might have pain occur on an empty stomach or after meal versus, patients with duodenal ulcer it might occur in the absence of the food buffer too, but I wouldn't get bogged down by that because you can't diagnose a patient based on that. The symptoms
They're
are
only just
all
going to
over.
ask us on our boards.
Yeah, that's only a board
I
question, so don't
remember
worry.
that it was like, I want to say, I don't know if it was Fitzgerald's or something going through, and they were asking that the difference or something with the gastric ulcer versus duodenal ulcer. I'm like, or gastritis versus I think maybe it was more in relation to gastritis versus a gastric ulcer, and when pain occurred, and I'm like, oh, like now being out in the field, you're like, I usually don't ask, do you have pain? We do ask pain, do you have pain after you eat a meal, or does it make it feel better? So sometimes that might be related to the gallbladder too. So don't get bogged down by when is it, but we want to know when it occurs. Complications, penetrating ulcers, perforation, I've definitely seen those. Gastric outlet obstruction, we see that a lot with like a pyloric ulceration or a duodenal ulcer. Hemorrhage, gastrocolic fistulas are pretty rare. I think I've seen one patient with one. And then death can occur. Diagnosis endoscopy, we typically do not biopsy if there's active GI bleeding. So if we have a gastric ulcer in there, we probably want to biopsy at that area, but if they're bleeding, we're not going to add to the potential for bleeding. So gastric ulcers require the patient to come back to document healing in about 8 weeks. So if you see them in the hospital and they haven't followed up, they come to you in the clinic for something, oh, did you ever get that follow-up scope for your, oh, no, okay, we might want to just take a look to make sure that's healed, and then we sometimes will biopsy in that 8 weeks from then. Sometimes if they have obstructive symptoms, we might do a CT scan. Labs, there's no predictive, no lab tests that can tell us if someone has peptic ulcer disease, but we might check, we're definitely checking the CBC. Do they have anemia? Fasting gastrin, more or less, now we're going into the more uncommon causes of ulcer disease, so that's not something we routinely do. H. pylori testing, okay? So you can definitely test. First of all, H. pylori is altered by acid suppression. So if a patient comes in and we have an EGD and we're going to do biopsy of the stomach, which is pretty much gold standard for diagnosing H. pylori, if they're on acid suppression, it can potentially, we could get false negative results, or if they've had recent antibiotic use. So we definitely would do gastric biopsies, but even then, we're not biopsying the entire stomach. We're only biopsying areas of it. So could we potentially miss an area? Sure. There is the serum H. pylori antibody testing that you could, order in the office. If you're in the office and the patient comes in and they have a lot of stomach issues and anything, well, I'm going to check an H. pylori. The problem with checking the H. pylori is it's an antibody that could be positive from infection from forever ago. That being said, I think some patients are still treated. They'll still be treated for it, but it can't diagnose active infection. Like if we do EGD with biopsies, but a thing that we can do is check stool antigen and if that is positive, that means active infection. But then again, you're asking the patient to do a stool test, go home, collect their stool, bring it back. The urea breath test is not something that we regularly do, but is listed in that. Treatment of peptic ulcer disease with acid suppression therapy again. PPIs are more effective than the H2 blockers for that, so we pretty much will put them on a PPI unless it's contraindicated for that patient or they can't tolerate it. 4 to 8 week treatment. And then maintenance therapy, you consider that depending on their history. Do they have recurrences? Do they have other symptoms that they just do they need that baby aspirin? And we suspect that might have been a cause for their gastritis or their peptic ulcer disease. Again, Carafate or Sucralfate is optional, but if they're having a lot of discomfort, we'll sometimes have patients on that. And then as avoid NSAIDs, smoking, alcohol. If patients are on aspirin therapy for cardiac reasons, we obviously, if they have to have that, we're aware of that, but that might be the case where you might keep someone on an acid suppressor indefinitely if they really need that. Treatment of H. pylori, again, so that would be diagnosed by a biopsy, EGD with biopsy, or stool antigen. Like I said, some people will do that serum antibodies, and they might treat someone for H. pylori, just based on that serum antibody too. So there is some resistance. It's treated with antibiotics and acid suppression. So it's triple therapy versus quadruple therapy, and I always have to look this up. So even if you have a patient coming in, you probably want to refer to us too if you have someone with H. pylori or diagnose. So we probably will start with triple therapy, and they're all alternates for patients who have. The
next one's diarrhea.
Oh. Okay. So they're all, if you have a patient that's allergic to amoxicillin, we can make alterations and medications for that, but I often have to look that up. And then important to H. pylori is making sure that you eradicated it. So that is when we will do this, the stool antigen. We'll check for that. typical therapy is for 14 days, and then I believe, I wanna say it's at a month, we check for stool eradication.
Okay.
Okay, that's right. You can see it, I can. So there ends part 2.